involved?
The Rural Collaborative Practice Model pilot was responding to a diminishing capacity for general practitioners to provide emergency services in smaller rural hospitals across Victoria. You might know that traditionally the GPs provide emergency services on call to the local hospitals, and with diminishing workforce capacity and also newer GPs wanting to have a better work-life balance, the load of the on-call load was falling to fewer and fewer GPs. A number of national studies have found that doctors and medical specialists diminish the more remote the communities are. This isn't the case for nurses. We found that nursing per head population remained relatively constant from metropolitan areas down to more remote communities. And I think it makes sense then to work with nurses to enable them to operate at a more advanced level so that the doctors aren't called in as often, particularly after hours. And that was really what this project was trying to get at. The collaborative practice model was very much about getting doctors and nurses and health service managers working together across 4 hospital sites and 1 bush nursing centre to develop solutions to issues that they identified around their emergency care services. Some of the strategies that they developed or they identified they wanted to implement was advanced nursing training and embedding clinical guidelines. The clinical guidelines that they looked at were the Queensland Primary Clinical Care Manual. The training that they engaged in, the nurses engaged in, was a modified version of the Queensland Rural and Isolated Practice Registered Nursing Program. And they actually called it, the participants in the program called it their Rural and Remote Advanced Practice Program. 18 nurses were trained in this program and it took 9 months. The program itself was based on interprofessional principles and they relied very heavily on local GPs to provide supervision and to teach them how to do certain procedures such as suturing and inserting laryngeal masks. The doctors were very much involved in providing support for the nurses to practice the new skills they were learning. Much of the work that was done and the success that we achieved was delivered by the people in the project. However, they did identify some issues that really were beyond their capacity to influence. An example was that they wanted to change the law to enable registered nurses to supply drugs. They gave that to the department to deal with as one of their actions, and they provided very good evidence to build a case to develop that proposal. I think another challenge was getting the nurses on board, actually, because we were offering this training program that wasn't recognised in Victoria. It was a Queensland training program. It wouldn't necessarily result in a higher education award, and indeed it wouldn't necessarily enable them to operate at the fullest scope of the practice that they'd be trained to do, because the law would need to change to enable them to supply drugs in order to do that. We've already found a number of benefits have come from this project. One of the key ones we were looking for was a reduction in the time doctors were called back to the hospital, particularly after hours. It wasn't a huge reduction, but it was a significant reduction, and that was possibly 9 months into the project. We also found the nurses felt more confident in their responses, and the doctors were more confident in how the nurses were managing patients. The nurses were, their competence had advanced or increased. There was better communication between the doctors and the nurses and also the clinicians and managers.
What we were looking at